So I'd like to thank Vincenzo for the kind invitation. So I'll be talking about management of anterior stromal complications after EK surgery. These are my disclosures that don't really pertain to what I'll be talking about. So endothelial keratoplasty has revolutionized corneal endothelial surgery in the last few decades, and we all know the benefits of a small incision procedure with fewer incisions, faster visual rehabilitation, and minimal ocular surface disturbances. And you can see the change in statistics from the EBA data, and this is from our Singapore corneal transplant data, with EK now being the predominant kind of surgery performed, with up to 60% of all the transplantations being performed, both in the USA and also in Singapore. However, the problem with EK is that, of course, it doesn't present the stroma, and when patients present later, as they often do in Asia, we can get cases like this where there's a lot of basically stromal haze, and then we're faced with a dilemma: should we perform a penetrating keratoplasty or should we perform an endothelial keratoplasty? Likewise, we also see more cases of bullous keratopathy in Asia, which almost account for 40% of our surgery. If you look at this graph over here, this is data from Mark Terry's group, you'll see 49% of the cases presenting in the US preoperatively had better visual acuity of 20/40. Compared to Singapore, this is only about 20%. In our Fuchs cases. In our bullous keratopathy cases, is about 2.6%. So patients are presenting much, much later. When you look at one-year data, almost 93% of cases are seeing better than 20/40, and this is very similar to our Fuchs sample, but this is certainly less compared to the data that we see from patients on bullous keratopathy. So in certain situations, we have to perform some alternative kind of surgery. This is an example of a lady who had previous intracapsular extraction and secondary anterior chamber IOL. One of my colleagues performed a DSEC in 2011. They never got better than 6/120 visual acuity. There was some chronic cystoid macular edema. When they were referred to me, I put the lady with a contact lens, and she was able to see 6/45 with a contact lens, but she was able to find this intolerant. So we performed a dog over her previous EK surgery, and this is similar to a technique that Massimo Busin described actually in 2011. So this is about the same time. So this is how we perform the surgery. It's slight variation to Busin's original technique. I use a freehand Solan Trifine, normally about at least 0.5 millimeters smaller than the size of my EK graft that's lying underneath there. And using a careful dissection, I'll basically dissect down on top to probably see where the basically DSEC has been performed. Once you actually find the interface between the DSEC, actually it opens up quite easy. This is a lamella dissector that we normally use for dog surgery. And once you're in the actual plane, you can open up the graft quite easily because the separation of the tissue comes away quite nicely between the recipient cornea and the previous DSEC. Interestingly, what you'll find is that often you'll see the area around the edge here where you can split the Descemet's membrane into two, and this is the area in the middle where the previous stripping has occurred when the previous surgeon has basically done his DSEC surgery. And once you basically pulled off the area, you put a full thickness donor tissue onto the surface. So this is what she looked like pre-op. This is basically what she looked like post-op, and obviously there was some good improvement with the visual acuity as we regularized the surface. So when we started doing these procedures back in 2011, we wondered about what was the quality of the interface. So we did some scanning. This is a picture of a patient who's had another previous dog surgery, basically over EK, and we did some studies looking at in vivo confocal microscopy to assess the level of the interface. And what you'll see is that there's no actual interface scarring, because it's like basically doing a Descemet's bearing dog procedure on the DSEC, even in the area where there's previous Descemet stripping. So if you look at the histology from this is an area basically I peeled off. This is what I've sent to the histology, to the microscopy, and what you can see is in the area in the middle over here where the stripping has occurred, there's no Descemet's membrane, but in the area in the periphery, consistently every time I perform the surgery, you can actually split the Descemet's into two. So the adhesion between the Descemet's and stroma is stronger than the adhesion between the two layers of the Descemet's membrane. So you can do much more complicated cases. This is also some recent cases that we've done. This is a patient who had a therapeutic penetrating keratoplasty on the right eye, followed by a DSEC. She then got a Pseudomonas infection on that eye. I did another therapeutic graft and followed it by another DSEC, and then she came back with a mixed bacterial and fungal infection on the surface over here. On the right-hand side, this is a patient who had a previous DSEC done with persistent epithelial defect and thinning on the ocular surface due to an E. coli infection, but with a functioning endothelial keratoplasty underneath this over here. So we perform these now for tectonic cases like on the right, and also therapeutic cases like you can see on the left. This is the surgical procedure. Now on the left-hand side, the patient's had a previous penetrating keratoplasty. So actually, once you find the plane of the previous penetrating keratoplasty on top of the DSEC, the surgery is technically slightly easier. On the right-hand side, when it's performed on top of an EK procedure, you have to be very careful about when you basically press onto the surface, because of course you can knock the EK graft off in the central area. And because it's a tectonic case over here, this is almost thinned out to a DMEC in the middle and a sort of DMEC around the periphery, as you'll see with the surgery. On the left, you can see this is the area of the previous penetrating rotating keratoplasty decimate. There's an EK procedure underneath there, but once you find the plane, you can do your dog on top. On the right-hand side, you can see the dissection is a little bit more difficult to do, and often you lose the anterior chamber, which you have to keep on refilling with air. But once you find the dissection plane here, you can see I made a DMEC in the middle and a DMake basically around the extra where you put the graft basically onto the surface. These are some of the results. So this is the same patient. This is at 6 months post-op. She's 624 now. We're removing the sutures on this side. And this is basically count fingers pre-op. She's 636, and we're waiting for basically suture removal. So we recently looked at, this is a publication of our first 10 cases that we've done in Singapore. We've done about 20 cases now, and we normally start doing a bit more cases even with tectonic and therapeutic cases. This is an example of what they look like pre-op, and this is an example of basically what they look like post-op. If you look at the visual acuity results from this paper, they're pretty good. We had one DSEC basically failure over that time period, which subsequently had a DSEC taken out, and we replaced it with a DMEC. But interestingly, if you look at the graft survival, it's very good, with over 90% survival up to basically 5 years. So we're looking at this long-term data, and these are patients with a functioning endothelial keratoplasty. So in summary, endothelial keratoplasty has revolutionized corneal surgery. However, patients may present later and have significant stromal scarring. In milder cases, we still perform an EK procedure, whether this is a DMEC or DSEC, and we basically try to do some visual rehabilitation with a contact lens. In cases that have a previous EK procedure with a significant visual deficit from scarring, we tend to perform a dog procedure over the previous EK, and this has offered significant improvement in vision. It can be used for scarring cases, but also tectonic and therapeutic cases like I've shown you. It maintains the functional endothelium, hence reduces the risk of rejection if you were performing a subsequently penetrating keratoplasty, because of course this will be the second endothelial graft. Our long-term results have shown good graft survival with good visual acuity. Thank you for your attention.